Welcome everybody to Global Response to COVID-19. This is a webinar number 7. This meeting is sponsored by the Panamerican Trauma Society, American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, and supported by University of Miami and Virginia Commonwealth University. Today we're gonna discuss the management of tests and how they can influence and how can help us in the decision to reopening hospitals for elective surgery. You have a good globe here, and also always remember, if you are in this conference, you are going to have your image broadcasted in our website. The presenters today are going to be Dr. Coimbra, that's the president of the World Coalition for Trauma Care, surgeon-in-chief at the Riverside University Health System Medical Center, and professor of surgery at Loma Linda University School of Medicine. You can have also Dr. Lilian Abbo, professor of infectious disease at University of Miami Miller School of Medicine, and chief of infection control at Jackson Memorial Health System. And we're going to have also Dr. David Hoyt, executive director of American College of Surgeons and professor emeritus of surgery at the University of California School of Medicine, Irvine Medical Center. Okay, so I'm going to introduce the other panelists. You're going to have also as panelists Dr. Thomas Scalia, executive director of Panamerican Trauma Society, professor of surgery at the University of Maryland School of Medicine, and physician-chief of the Shock Trauma Medical Center. Dr. Maida Velasquez, professor of surgery and chair of the White Downtree Family Department of Surgery at the University of Miami Miller School of Medicine. Dr. Tina Garner, director of trauma and consultant general GI trauma surgeon at Oslo University Hospital in Norway. Also Dr. Lee Haisi, trauma emergency surgery and clinic director general surgery at Auckland City Hospital in Auckland, New Zealand. And Dr. Michel Aboutanos, he is a professor of surgery and chief of division of acute care surgery and services and medical director of VCU Trauma Center. He is also the chair of the AAST International Relations Committee. So I would like to invite Dr. Coimbra to welcome all the other partner societies that are joining this network for 7 weeks now, please.
Thank you, Antonio. I would like to start by congratulating you and Michel Aboutanos for this initiative. This is very important. This is webinar session 7. And on behalf of the Pan American, the AAST, the World Coalition for Trauma Care, University of Miami and VCU, I want to welcome so far 126 attendees, which is quite amazing on behalf of all the professional organizations that you see listed on the screen. It's a tremendous global effort, and I think many good things are already coming out of this initiative. So again, welcome you all and congratulate you. Thank you.
Thank you very much, Dr. Coimbra. So let's start the first presentation of today. The first presentation is going to be performed by Dr. Lilian Abbo. She's going to talk about COVID-19 tests, how can they be used, and as we resume elective surgery. Dr. Abbo, please.
Good afternoon, everyone, and thank you again for the kind invitation. Give me 1 second so I can share my slides very quickly. Okay. All right, can you hear me well? Good. So I presented last week the management and I had some disclosures. So my disclosures this week have changed. As you all know, I'm not a surgeon, but I'm also not a pathologist. So I'm going to give you my perspective as an infectious disease clinician and a leader in the front lines, trying to put all this confusion together. And I hope that by the end of this talk, you have a little more clarity than me. And the information of diagnostic tests, like everything related to COVID-19, changes every hour and evolves daily. So anything you hear today may be the same tomorrow or may be completely different. The Centers for Medicare and Medicaid have recommended that if we want to reopen facilities, which is what all of you are eager to hear and see today, is that we take some measures into place. And the first thing we need to assess is the workforce availability and also our testing capacity. Anyone reopening, whether it's a store or a hospital, we need to have the capacity to start screening for symptoms of COVID in anyone who's symptomatic, and we need to have the capacity to test them if they have symptoms and quarantine them. And that is extremely important, as they're trying to limit the workforce from working in areas that are in a COVID zone from non-COVID zone, instead of having people rotating, this morning you're in the COVID zone and from this patient is COVID and the next patient is non-COVID. They're really recommending we have COVID dedicated areas and COVID dedicated step down areas. So as you're working with your hospitals, those are the things we need to start planning. The testing capacity also has to be for everyone with potential symptoms entering the facility. We should be screening staff, either self-reporting or checking temperatures, and we really need to start taking care of that. And also, once you have adequate testing capacity, CMS is recommending that we should be screening by laboratory testing all the healthcare workers. And that to me is a difficult to implement recommendation in the current state, at least in the United States, and I'm eager to hear what are other countries doing. And then the question is, once you test, how often do you continue to test? So as of April 27, the CDC just updated the recommendations and priorities for COVID testing, and they're recommending that if you're going to be testing, you should be testing anyone with symptoms, hospitalized patients, healthcare workers that are symptomatic or living in congregated facilities, first responders with symptoms, and residents in long-term care facilities, or anyone identified in contact tracing and a cluster. So that is important. And now they also updated the recommendation that we also be prioritizing asymptomatic contacts if we have any other reason for public health monitoring or sentinel surveillance. And as we're a complex health system, I'll show you one of the things that we have been able to implement here. So as you remember, Jackson opened in 1918, actually during the flu pandemic. And our hospital now is not just a hospital, it's a whole health system that is very, very complex, and we take care of transplant, trauma, pediatric. We have a behavioral health hospital, 2 community hospitals, multiple clinics, 2 ambulatory long-term care facilities, nursing homes, 4 urgent care centers, and we take care of the inmates and the healthcare workers of 4 Miami-Dade County jails. So this creates opportunities for surgeries, opportunities for reopening, and again, how are we going to test all these healthcare workers and all these patients in all these sites? And just last year, we performed as a health system 24,000 surgeries, 15,000 were inpatients, 9,000 outpatients. So now we need to have testing capacity if we want to ramp up our operations to be able to test all these people. We have done different strategies in terms of indications for COVID testing. This has evolved and it changes very frequently, but we are testing symptomatic and asymptomatic patients. And as I mentioned last week, we have started to screen patients since January based on the CDC criteria. Initially, we had to send the test to the DOH, and then around middle of March, we discontinued all elective surgeries based on the order from the governor. Although we still continue to do much lower than our normal volumes, we continue to do trauma, transplant, and emergency surgery. So we never completely closed down. We have a no visiting policy. We have mandated universal masks for everyone because since the middle of March, we were concerned that asymptomatic people, including healthcare workers, could be shedding virus. So we implemented the surgical mask as a way of protecting others from us. We also started the in-house PCR testing, and by now we're doing universal testing for all preoperative procedures. For labor and delivery, we're testing the pregnant mother who's coming in labor or any elective surgeries, but we're also testing the partners, and that has a separate algorithm once the baby is born. We're also testing all hospital admissions, and we have different tiers depending on the acuity, the severity. If you are a stroke patient or if you're a trauma patient, we test you on the rapid platform. platform, less than 45 minutes, we have results. In some of our hospitals in less than 15 minutes. If you're an elective admission, a surgical admission, we test 48 hours before, and usually in the platform that takes around 24 hours turnaround. So we don't have a surplus of reagents, so we have to create tiers to prioritize. Of course, everyone wants their test in 45 minutes or less, but we need to use resources wisely in order to be able to take care of absolutely everyone. And our priority is always the symptomatic, sick patients and people who need to come in very quickly. So we have also been validating the antibody testing, and I'm going to be sharing with you what are we doing with serology. These are the numbers for our health system as of this morning, 7 a.m. So far, we have tested in total, since we started the pandemic, almost 9,000 patients. The majority have been outpatients. We have 1,358 positive cases, so the positivity rate is around 15%. In pediatrics, it's less than 5%. In outpatients, is around 8%, and in the hospital, depending on the zip code of the hospital, some are around 28% and some around 18, 19%. So we see a small, stagnation of the curve, but we're still not dropping dramatically our numbers. And the majority of the patients right now are non-ICU, and we're seeing long lengths of stay. So the good news is that we're keeping people alive in some areas. In other areas, we're seeing very fast mortality. Patients are coming in very sick, and by the time they present to the ER, they have already severe hypoxemia. Some of them are elderly, being transferred from some nursing homes, and are coming in very ill. So what are some of the dilemmas that I hope we can answer today? How can I explain the different platforms and the sensitivity? And how do you understand if your test is a true positive or a false negative? Should we test asymptomatic patients? And for how long is the PCR going to be positive? And actually, does it matter? And I have the same approach that I have for treatment with diagnostic stewardship. Sometimes we need protocols and we need a recipe that will work for all, but in other scenarios, we're going to have to individualize the care, and maybe it's a combination of tests that are going to give us the right answer. So we need to start doing, tailor-made measures and how to interpret the results depending on your scenario, and one size may not fit all. This paper is actually for evidence. COVID, it's from the United Kingdom. It's not a peer review paper, but actually if you want to review what are the pros and cons of every diagnostic platform, I recommend you review this paper. It's available online for free. And pretty much the authors explain that some of the differences between the PCR, the LAMP, the lateral flow assays, which are the antibody testing, and the ELISA. And the difference between these two is that the point of care testing, you pretty much can do one patient sample at a time. So it may work well in a drive-through clinic, but if you're doing massive testing, you may need to use an ELISA platform where you can run, in blood, not a point of care, over 100 samples at a time. So you need to understand what are your needs, what is your capacity, what population are you serving? Are you working in your private office as a dentist or as a physician, or are you working in a large trauma center, and how do you deploy these strategies? Now, this is something that has evolved very quickly, and the question is, are all PCR platforms created equally? So I went to our medical director of microbiology, and he said that so far all the information is from manufacturer package inserts. So do we have no data on sensitivity and specificity? Also, they are reporting the characteristics as some percent agreement between the platform that they tested and some other test that we don't know which test is that. So it's a little confusing. And then there are many differences in what they call the lower limits of detection, and the amplification methodology, the instrument they use, the method of target extraction, the substrate, and the dilution matrix. So it's almost impossible to compare these platforms and tell you which one is more sensitive and more specific. So Dr. Martinez was kind enough to share with me this table where he created, looking at the package inserts, and at least in red, I'm going to show you the test that we have in-house at Jackson. We have the ELITech, which gives you a turnaround between 4 and 6 hours and can detect 10 copies per reaction, but it uses the subset of a target RNA. The Cepheid gives you the result in 45 minutes, but it's a different limit of detection. It's 250 copies per ml, so I don't know how to distinguish 10 copies per reaction from 250 copies per ml. This is considered one of the state-of-the-art in the industry. So we're considering so far the Cepheid as the best test, but I don't know if this is anecdotal or really evidence-based. And then we have our in-house test that is the Genentech, and the Genentech is between Q12, Q24 hours, depending on the operators, and gives you 500 copies per ml. So it's a little, Cepheid can detect less copies and give you more information very quickly. And then the Abbott ID Now, which is a 15-minute test and gives you 125 genomic equivalents per MA. And this has been in the news and many parts of the world, or at least in the US, considering a less sensitive test. And what the company found out is that the viral media was inhibited the viral replication. So they came up very quickly with a solution that you should put the swab directly into the instrument. And that apparently improved the performance characteristics of the test. So I go back to, you need to understand which test are you using, what's the target, what's the limit of detection, so then you can better understand, what you're dealing with. The other option is antibody testing, and IDSA came up with recommendations that it should not be actually used for the diagnosis of an acute infection, but it could help perhaps in patients that have PCR negative cases. So when you have these situations where you don't know if it's a false negative PCR, perhaps the serological assay may have a role. Also, it might be able to help with convalescent plasma donors in epidemiological studies, population health, or when you have to test massive people, this might be a more cost-effective solution in asymptomatic patients. But the big questions that remain unanswered in the ID community is, we don't know if you develop immunity to this virus. We don't know if the fact that you have antibodies means that you have immunity. Some people may take longer than others to develop antibodies, and we cannot use this test for the diagnosis of an acute infection. Still, the gold standard is becoming the PCR. So we have a few, serological tests. One of them is the lateral flow, which looks like a pregnancy test. You can do it very quickly in 15 minutes, but this is not FDA approved as a point of care test. So we did some internal validation in our lab, and we're finding that some asymptomatic patients still after 32 days have positive IgG, but their PCR is still positive. Another patient, the same duration of time, cough has resolved 7 days without symptoms, and initially had only cough, never had big symptoms, never had a fever, never had hypoxemia documented. But this person, after 33 days with no cough now for 7 days, still has presence of IgM and IgG, and their PCR is still positive. So the question becomes, do you let them return to work? You don't let them return to work. What do you do with the PCR? And what do you do with someone who still has IgM, which is your early antibody? So then we took and we did a pilot on some patients who had a previously positive PCR, had been out of work. They had been quarantined for over 14 days. And then we took and we repeated the nasal swab PCR on them. And we took a sample of 45 people and voluntarily asked them to give blood to check their antibody titers. And we wanted to see if there was any correlation in your convalescent period between your PCR and your antibodies. So what we find in some of them is that their PCR now was negative. They recovered from the disease, but look at the antibodies. They were non-reactive. So they had no detectable antibodies, and this was way over 14, 20 days. Then we had another group that had negative PCR, but they had good detectable antibodies. They were reactive. And then we have another group that their PCR is still positive, way over 25, 30 days. And some of them have antibodies, and some have non-reactive antibodies. And this one is a person who was intubated, critically ill, recovered, but we can't explain why they don't have now reactive antibodies. So these two, for example, would not be suitable candidates for plasma donation, perhaps, because if they're donating plasma, they don't have detectable antibodies. The question is, what do you do with the group in red? Do you let them return to work? They have antibodies, and this platform doesn't give me IgM or IgG, it's a combined antibody. Abbott is coming up with a just IgG antibody, which maybe will be more helpful, because this combined antibody, right now, it's a little difficult to interpret. But I want you at least to be aware of how confusing is this process. So the next question is, should we be testing or not asymptomatic patients? And this paper just got published in a New England Journal looking at nursing homes, and this was in Washington State, where we had one of the epicenters in the nursing homes and the highest mortality rate. And what they looked here was for positive cultures, negative cultures, or no cultures. So they did viral cultures, and they also did PCR. And they divided the group in 4. The ones with typical symptoms, the ones that had atypical symptoms, no respiratory, but had like perhaps some, confusion, altered mental status, and then the pre-symptomatic, and then the asymptomatic. What is very interesting is that the viral loads were very similar in all 4 groups. So it's not that the ones who get sick had a very high viral load, and if you're asymptomatic, you're less infectious. And they found out that 71% of these pre-symptomatics had actually viable virus in a culture 1 to 6 days before they develop symptoms. So I think this brings a very important point, because if you can see here at that -6, these patients already have positive cultures. And that means that they are potentially transmitting to other people. And that's why this virus is so difficult to control, because asymptomatic people are transmitting disease. There's a nice editorial from the same article that really says this is why we need to, run these strategies in this population, especially in jails and other areas. So my question to all of you is, what do we do with this information? Do we continue or not airborne isolation? Can you take your patient to the OR? And when do you go back to work? And just to finalize, these are 2 papers coming from Nature that are actually showing that the fact that you're shedding or detecting virus after 35 days is not correlating with viral cultures. And what they're seeing is after day 9, none of these cultures seem to be viable. So the CDC is very soon apparently going to change the recommendations, because we really need to understand that even if you have a positive PCR beyond 10 days, perhaps you're not as contagious or you're not contagious, and you need to tailor these strategies and understand if you're going to start doing wide testing of patients and healthcare workers, what are you going to do? How are you going to use your PPE and your testing? How are you going to use your finite resources, and how to interpret these results? Perhaps a combination of serology with PCR might be a strategy. We're not there yet. And again, the difference between the difficult and the impossible is that the impossible takes a longer time. So I think it was almost impossible to summarize everything in 10 minutes. And I'll be happy to have a great discussion with the panel and hear from others. Thank you.
Thank you, Dr. Lilian Abbo. Looking forward for discussions. Let's go to Dr. Raul Coimbra. Dr. Raul Coimbra, you can have a presentation, and then you can introduce Dr. Hoyt, please.
Thank you, Antonio. So I'll try to very briefly set the stage for Dr. Hoyt's presentation. I'll speak to you a little bit about surgery in times of COVID-19 infection. In fact, despite much discussion about reopening the operating rooms, we never completely closed for surgery. Obviously, busy hospitals that are trauma centers that have a high volume in the emergency department of cases for emergency general surgery continue to do cases. Others continue with transplantation and time-sensitive disease such as cancer. But we worked on a different framework during this last month and a half or so, and several professional organizations have made recommendations for setting up your hospital ORs to function in a limited way during those times. So trauma, emergency general surgery, cancer, and cases that there was a risk of harm if procedure was delayed were continually done during this time. The question really is, how do we go back to normal? We obviously need to understand COVID-19 prevalence and assessment in the community. We got to look at our hospital bed availability. Actually, with all the surge plans, we never filled even 35 or 40% of our beds, at least in California, although things have been a lot worse in other places such as New York. We need to look at other hospital resources. Obviously, the testing capacity is the cornerstone of this plan to reopen. Many of us are already making an assessment of our backlog to ramp up elective surgery through a case prioritization process. And in many hospitals, the discussion whether you open up for outpatient surgery only versus inpatient is taking place as we speak. There are national, federal recommendations about how you analyze the prevalence and the assessment of the disease in the community and in the hospital. And all of you probably have seen those documents. Again, bed availability is unique to each hospital, and one has to decide what is the number of bed utilization below which you are safe to reopen your hospital, as well as other resources. The PPE issue is still very important, and we have the responsibility to prioritize use of PPEs and such as N95 masks and other pieces of equipment to our operating rooms if we are to reopen in a safety way. Medication availability is another important point, because many shortages of many medications have been reported during the last month and a half. Testing capacity, you just heard, I won't dwell on this. It's still confusing, but I thank Dr. Abbo for clarifying several of the points that we are all asking about. Assessment of backlog in elective surgery, we are doing this by specialty, obviously. Many discussions about cancer versus non-cancer, inpatient versus outpatient, whether or not the patients will require ICU admission, and whether or not there is risk of harm if you delay for another 6 to 8 weeks procedures that were previously scheduled. So all these discussions must take place, and every hospital will find their unique solutions for this. In our case, for instance, we have a brand new outpatient surgical center that we will use as a COVID-free facility, if you will, to ramp up initially outpatient surgical cases, and then in a different stage, we're gonna go to inpatient. Case prioritization, some are using the ASA system that anesthesia uses, and there is this very nice paper in press in JACS that talks about a very nice risk assessment tool for case prioritization, and I would recommend all of you to read this paper. So we need to discuss options, obviously, but we need to do this in my opinion, in a staged process. And whether you decide to do this based on percentage of your OR capacity or types of cases is a unique solution and discussion in your own hospital. For us, stage one could be done if we ramp up 50% of OR capacity. And this is just an example for discussion purposes only. What do you do with the blocks that were already assigned prior to COVID? Should it all be open blocks? What's the contingency plan for extended hours to be equitable? Obviously, we always have trauma and acute care surgery rooms available, but for elective surgery, things, there are many, many details that we need to think through, particularly how we are gonna redesign our blocks. We are gonna do this in stage one in our facility, and then have a 2-week period followed by a reassessment. And obviously, if we are ready, then we'll move to stage two. There are some tenets during stage one that I would like to share with you. Obviously, the principles are important. Do no harm, patient safety and team safety, they all come together and they should be the priority. We in our facility decided that we are gonna go with outpatient to avoid hospital admissions and flow of patients in areas that could potentially lead to cross-contamination. We have made a decision that we are not going to operate electively on COVID-19 patients during stage one. So if you're going to open for outpatient, we are going to test everyone, and those that test positive go back to the end of the line, and we'll have to wait 4 to 6 weeks. We have a responsibility to explain the safety measures in place to our patients. And this question of testing staff and surgeons is lingering out there, and I hope we can discuss this at the end today. So again, patient safety and staff safety is very important. And even if you do all the things listed in this slide and you reassure the public in your area that you are a safe institution for them to come, will they come? Many people lost their jobs, many people lost their insurance coverage, many people do not want to come to the hospital during these times. Explaining risk to patients of testing, the value of testing, and the risk of acquiring COVID while in the hospital is also part of our responsibility as surgeons. On the day of surgery, we are not allowing family members in the facility Everyone will be masked. They will be screened with a questionnaire that recommended by the CDC. We're going to test everyone up to 72 hours prior to the operation. And if it's more than 72 hours, then they will be retested with a rapid test on the day of surgery. We are developing a process to give discharge instructions to the patient and to the family by calling them. They should be waiting in the parking lot. We'll set up curbside pickup to avoid traffic of family members in the hospital. And as much as possible, they will be seen by using telemedicine when possible for a post-operative check. Stage 2, we are going to ramp up to 75% of our OR capacity, and we're going to start doing some inpatient cases. And the same discussions apply to stage 2. Should we still keep open blocks during stage 2 and allow people to schedule as they want, or should we go back to, or should we redo our block time grid temporarily during this stage as more inpatient cases come through? And then finally, stage 3, when we are fully open, 100% of OR capacity for inpatient and outpatient, we plan to go back to our regular block time grid pre-COVID, and we will reassess as we go along. You know, sometimes 2 weeks, sometimes 4 weeks of assessment. So in summary, at least for our phase 1, this is our setup. We see the patient, we decide patient needs an operation, patient goes to pre-op clinic, he's tested. If positive, goes back to the end of the line, and 4 to 6 weeks later will be reassessed. If test negative, goes to the operating room, then goes to the recovery period, always thinking about patient safety first. And obviously the prerequisites of PPE availability and personnel availability, drug shortages having been dealt with, etc. And most important, the test on hand prior to surgery need to be in place. I will stop here, and thank you all very much for your attention.
Thank you, Dr. Coimbra. So Dr. Hoyt is joining us. Could you please introduce him?
Of course. It's a great pleasure for me to introduce Dr. David Hoyt. Dr. Hoyt is the Executive Director of the American College of Surgeons and Emeritus Professor at the University of California, Irvine, where he was Chair of Surgery for several years. Dr. Hoyt in the college has provided tremendous national leadership and international leadership during these times of COVID. If you go to the college website, you find a tremendous amount of guidance for surgeons in the country in all settings. The college has moved from a North American organization then to an international organization. Today, the college is a global organization, and we appreciate the efforts of the college, and it's a pleasure to have Dave here today. Thank you so much, Dave.
Well, thank you, Raul, and thanks to all of you for inviting us to share some thoughts. Okay, so again, thank you very much for having us participate in this. And when I put these slides together, I really realized that a lot of what I will say is probably redundant from what you just heard from Dr. Coimbra, but I think that's okay, because I think it represents that we're all facing something new for the first time. We're all sharing how we're going about it. There are no exact rules of engagement. And what I've done is take what our guidelines in the American College of Surgeons that were produced about 10 days ago came out from a consensus of many people discussing this and sharing the problems. And we tried to put together basically a checklist in 4 domains of thoughts to help guide you as you start to ramp back up. And it's very similar to what we did about 2 months ago when we were asked to approach how do you start to limit elective surgery. And we put out some guidelines then. Those were actually, if you recall, quite controversial. We all sort of went through a period of time when we didn't quite believe that this existed, and it couldn't touch us, and it certainly couldn't affect surgery. And if we didn't see people walking around symptomatic, what's the big deal, et cetera. that has been a problem all along, but I think we've come together as a community, and what I'm going to show you represents our best attempt to interpret what's going on, realizing that that's going to continue to change. So the focus today, I think, is what we're calling ramping back up, so that that becomes a whole set of focus that we're all dealing with today. If you go to the next one. Go to the next slide. The first thing you have to really ask yourself is when is it appropriate to do that? And I think we've all been thinking about that. We found this document that you see here, and we've referenced on our web pages, the most useful. It's a study that was done by Dr. Gottlieb, and Mark McClellan is also an author on this. He moved down to Duke, and this is a product from the Duke so-called American Enterprise Institute. And they tried to model and put language on an epidemic for us. Most of us have never dealt with an epidemic like this. And they created the concept of phases that you go through. And a lot of that language has now been adopted nationally to describe things. But basically, what they tried to say is that you're leaving so-called phase one, or the period of high vulnerability, when you follow the time course of the disease. So the 75th percentile of incubation prior to the development of symptoms is 7 days. So that means if you're asymptomatic, that 75% of patients will have no symptoms during that period of time. And then the maximum incubation period is 14 days. So with that observation and that language, it does seem reasonable to say to measure your peak, watch your incidence, and when you've gone 14 days in a community or a region with no increase in incidence, that you're probably transitioning to a point when you could safely provide surgical services. So that's the basis of it. That peak, that timing is going to occur in every part of the world at a different time. And that's why there has to be so much regional control of this, working with government, working with the local authority. And as you've seen in the last couple 10 days, the regional interpretation of this is starting now. State governors are working with counties, they're working with hospitals. But for each of you as an individual leader in your hospital, I think having some rationale based on this kind of thinking is the best way to do it, and the reference is there. Next slide. The other thing is to have an awareness not just of the overall rate, but to understand your rate overall in your local area. Otherwise, it's going to be hard to know whether you've actually mitigated the virus locally. And it's still important to continue to track that, because if you start to reopen surgery, start to reopen social distancing, any of these things we're all having a discussion about, if you're not continually ongoing and measuring that and know what your rate has been, then you might not recognize a spike in that rate. And so you want to think about that as well. And probably more so than any of us have paid attention to it up till now, we want to think about that as we start to get back to normal, so we can recognize a recurrence or recognize a new spike, and then reestablish social distancing or shut down elective surgery again. So those are the two components about knowing your rates. One is when to start it, and start it safely based on the science of what we know about the virus's behavior, and then know how to calculate what's going on in your community. So as you start to reintroduce looser controls over things, you can decide if you've got an ongoing problem. And you'll see there's a big controversy in the last 48 hours with a couple of emergency medicine folks actually in Bakersfield, California, measured through their clinic the incidence, and found that the incidence of positive is very high. And so their conclusion was, this is not a big deal. The mortality is very low. All these patients we tested positive None of them died, and therefore we're overdoing the problem. The problem is that they did not use any kind of scientific sample. And so what they did is they got on a news conference and basically tried to tell everybody this is not a big problem. And it was just based on misinformation. So we really got to be careful in our leadership roles as physicians today to know what we're talking about. And if we don't know, say that. But most importantly, try and have in your community some way to measure this so you make thoughtful decisions. Next slide. Now, I know you talked about diagnostic testing, and I won't belabor it. And I have put a lot of words on these slides because I figured that some of the content people may not have access to our website, so that at least you could use these for your own tools. And any of these slides you can take and use any way you want. But you've got to know something about the local diagnostic testing capabilities and turnaround times. And again, a lot of the people that are speaking with authority today are those that are from academic medical centers where they've either been able to get access to these tests or have developed their own. Some of them are have been leaders in this area. But the problem is that the same thing is that at a time of vulnerability when we're all learning, we're liable to overemphasize or even make mistakes about judging things too quickly. And so, for instance, the rapid tests that were promoted several weeks ago have turned out to have a very high false negative rate. And then people will say, well, you can use them twice, and then that increases accuracy. And that's probably true, but it's still, there's a vulnerability, and there's no consistent available test right now that is 100%. So if you're going to use this, just be aware of its limitations. There should be policies that are followed, and what Dr. Coimbra just described they're using in his hospital, those are good policies, but just realize they're not perfect. And from the standpoint of going back to surgery, is a patient that tests negative really negative? We know that that's not a true statement. And so as you think about this, some people are introducing, in addition to testing for elective surgery, if a patient is going to be in the queue to have their surgery, asking them to quarantine on top of that, or at least keep themselves relatively isolated for those 2 weeks before their surgery. That's actually what the practice in Canada right now is. So everybody's trying to come up with a way to assure themselves they're not putting themselves or their staff or the patients at risk. And it's just an imperfect world at this time. The other thing to consider is the last bullet point on this slide, and that is you've got to have some way to think about how you're going to use testing when a patient postoperatively develops a fever, gets atelectasis, has a small infiltrate on their chest x-ray, because it's going to be very confusing. And again, you can test those patients to try and assure yourselves that there's at least possibility of a COVID positive patient, but it's not going to be 100%. Next slide. Now, with the PPE, this has been one of the most difficult and controversial areas in the last couple of months. And you've seen people going up against institutions and, if you will, having really distressing arguments over that. I mean, it's all driven by the same thing that we were all thinking about when we dealt with AIDS or any kind of issue such as the scare with anthrax 20 years ago. We're thinking about the safety of the patients. We're thinking about the safety of ourselves. We're thinking about the safety of our families. And all of those are, in my opinion, laudable concerns to have. And the N95 has been particularly complicated because of its availability. What this does in the return of elective surgery is most people probably have pretty comprehensive practices right now for how they're using PPE in the hospital. But the real question is going to come down to, if you're going to operate on a patient that tests negative, should you move to maximum PPE, which is an N95? I don't have the answer today to tell you that. I can tell you that there are some recent guidelines that I believe were published today or are about to be published today from endoscopic societies that have weighed in on this same issue with regard to colonoscopy. And probably, at least the best way to put this is the best practice is to use an N95 if you're not sure. And basically what we just said about testing is you're not going to be 100% sure. But the practicality of that and whether you have the supply to be able to do that, whether you limit surgery until you have that status, that's going to have to be an individual decision. What we have suggested in our guidelines is that for institutions where the incidence has been low, so if you go to rural America and there's been a low incidence overall, that their peak has gone past or never touched them, that they have a patient population that is basically healthy and has been, can be validated to have been healthy and asymptomatic, that doing elective surgery without maximum PPE in that circumstance will occasionally be the right decision. And you're going to start to see that as hospitals ramp up. But this still continues to be an open dilemma, and it's because we don't have a perfect testing test, and we don't have a complete supply of personal protection equipment. I think another way to think of this is for people to adopt a policy of universal precautions, whether or not that includes an N95, probably is a good practice. So eye coverage, shield coverage, masking, etc., all that should be pretty routine in every institution. Next slide. Now the capacity issues, again, as Dr. Coimbra pointed out, is a very local decision, and you have to, what we've put together here is some things for institutions to consider without trying to give you advice. Everybody knows their own operating schedule better than any of us that would be giving them advice would. And what you have to do is to think about several broad issues. One, how quickly do you want to reach to catch up? What's the order in which you're going to do that? And then how do you maintain the services while you're doing that you need? If you're a trauma center, you need to be continuously concerned about having beds available to care for trauma patients or stroke patients or heart attack patients. And that actually became a problem in New York City, where they got overwhelmed, and they still had the responsibility in their community to provide emergency services. And they got ultimately overwhelmed in some hospitals to the point that compromised that. So you've got to think about that. You've got to share resources if that's been a problem. And then you have to have some systematic way to bring patients up. We've tried to create guidelines for cancer. We have them for lung, breast, colon, and now prostate as of yesterday. And those are very useful in those patients where there's perhaps the most urgent decision making. But a system that looks at your capacity and then matches your backlog with that capacity is really the most important thing. Next slide. It's really important to think about our colleagues. And I read yesterday one of the most compelling things I've read. I've read a lot of things about physicians, but don't forget our nursing colleagues, because they are in the middle of this even more than we are as physicians. And I can't really speak with authority about this because I'm not currently practicing, but I do know that from years of taking care of patients in the ICU, et cetera, that the nurses are really the ones that are in the thick of it. And I don't think we've spent as much time as we need to thinking about the stress that this has caused them, not just the personal stress, but the stress of dealing with these patients, having these patients die without being able to be with their family members, and how all that has affected our healthcare force. So think about it. I would encourage you all to really reach out within your hospitals and spend extra time thinking about your nursing and other non-physician colleagues. And as you start to ramp up, don't just expect them to be able to jump right back in the queue. I don't know what that means, except you all do know what it means. And so I'm just encouraging everybody, and we're trying to encourage people as a college to be sensitive to that and create PPE policies that protect workers. Consider these levels of stress and fatigue. Don't try and ramp up so fast that people can't support it without getting burned out, and just be sensitive to that. Next slide. Now, one way to do that, and we emphasized this in particular when we were ramping down, there was a lot of concern how you would make selections or decisions about curtailing elective surgery when that was a problem, in particular over the about 2 months ago. And we suggested at that time to create a governance committee that would be multidisciplinary. This led us at a national level to collaborating with anesthesia and AORN and hospital administration. We have put out collaborative statements regarding that. But the basis of it is come together in an institution, work together, have some way to triage the patients in ramping down. And the obverse of that is to have a systematic way, a governance committee that looks at how to make these decisions, to communicate these decisions, how to work with all the staff and all the contingencies, such as nursing and the things we've talked about fatigue and burnout, so that when we do this, we do it together. And there are all kinds of additional specifics that are listed here that you can address. But I think the most important thing to do is have a clear, visible, transparent way to go about it, that everyone's represented, and have a strong surgical leader that's committed to that. Next slide. Patient communication, very, very important. We're hearing preliminary reports, as Dr. Coimbra just talked about. When you reach out to people, they're not necessarily willing to have their surgery. I just talked to one of our regions from Atlanta, who's finding that 70% of patients that are being offered to return to their operating room are saying, no, not quite ready. Another institution, 40%. So we all understand the economic pressures to try and do this, and hospitals are hurting, surgeons are hurting, and people are very interested in trying to get back and catch up and get back to normal. But it's probably not going to happen as quickly as we think. And part of this is that patients are going to be cautious. And if it's truly an elective procedure, they may want to just wait a little bit longer to make sure things are really, really safe. So I think communicating with them, whether it's with video conferencing or frequent communications, as patients have had to suffer or endure a delay, as many people have done, keeping that going and really working very hard to assure patients is going to be a very high priority as well. Next slide. Now, regarding prioritization, I'm not going to try and give you a solution. I would refer you to two resources. One is the web pages of the American College of Surgeons COVID site, where we have, for cancer, we have put up many resources. We have linked to every specialty society that has that. Again, this has got to be a collaborative discussion between surgery, anesthesia, nursing, and others. There's got to be a process, ideally, that is a governance committee that looks at that. And then the decision-making factors need to be very transparent. Next slide. There are things or tools that will help you. One is a list of your canceled cases, obviously. Hopefully people have that, and that will help them get started. There's some objective priority scoring systems. The MENTS is we've mentioned that on our webpage and in our newsletters. That was developed here in Chicago at the University of Chicago. It's not perfect. It's one way to look at it, and we highlighted it because it was a thoughtful example. But there are other ways to do it, and ultimately surgical specialties are going to have ways that they look at things, and you just have to work this out at a local level. But those tools are starting to appear, and they can be very useful. And then Dr. Coimbra has already talked about deciding how rapidly and in which operating rooms and what capacity you'll have, and all of that will help you. Next slide. This just shows you, using that tool, how you can score patients. And having said that, I'll tell you a controversy that's already come about with this. So for instance, the University of Chicago scoring system basically uses several factors, including patient risk, the urgency of the procedure, comorbidities, et cetera, and then puts a numeric score on it. And you can see the way they then, in their publication, suggested you might use this, that people with a low score, that you could move on them quickly, and patients with a high score, you might wait. The problem is this is subject then to interpretation, and the bariatric surgeons recently had a webinar like you're having today, and they actually said, well, you know, this is a great way to score patients, but actually I think the highest scored patients, the most at risk, should be the ones that should be done. And so those kinds of disagreements or perspective have to be represented, and I think the most important thing is to people work in a local governance structure so that as each hospital comes forward, they do it in a collaborative way. Next slide. Again, just more detail, issues to be considered as you increase OR volume or expansion, cleaning, and whether or not you have to reconvert rooms from positive pressure to negative pressure, et cetera, et cetera. All of those are details that you all are very well versed on. And it's why there has to be a collaboration, because our expertise as surgeons does not necessarily extend to sterilization and things that the operating room nurses would be expert in. Certainly it's true with our anesthesia colleagues. And if we all do this together, then we're much more likely to be successful without a lot of extra stress. Last slide. Finally, this is about the operating room. It's about restarting surgery, but it'll touch every part of the perioperative process. And so if you go to the last slide, then we've tried to put together a table that just reminds you of some things to think about in each of what we call the 5 phases of care. When we put the Red Book together several years ago, we divided surgery into the preoperative period, the immediate preoperative period, the intraoperative period, the postoperative period, and the post-discharge period. And each of these has elements that are, as we reassume surgery with the COVID epidemic, that we're going to have to rethink or make sure that we've checked, does this have any implications for COVID? So we put this little table together to help guide you in your thinking, and hopefully you find it's useful, but it's not definitive. These are really offered as suggestions. So Dr. Coimbra, with that, I'd be glad to take questions with the rest of you. Thank you very much.
Thank you very much, Dr. Hoyt. Let's move quickly to our panelists, and we'll give each one of you an opportunity to make comments or ask questions that may be representative of what the 160 people watching this might ask. Let's start with Dr. Almeida. Your initial comments, Dr. Velasquez.
Thank you. I want to thank and recognize Dr. Marttos for putting this venue together, and congratulate Dr. Abbo, Dr. Coimbra, and Dr. Hoyt for their presentations, which are extremely informative, very, very helpful. At the University of Miami Hospital, where I am overseeing some aspects of the recovery phases and the preparedness and planning, we followed a lot of the principles that were covered in these presentations. For example, we had prepared for the eventuality of having up to 200 patients in ICU and an additional 200 patients on the floors. And we had a number of layers of cross coverage that included every physician potentially participating in the response. And then over the last 4 weeks, we noticed that we plateaued at around somewhere between 35 and 45 patients in the ICUs. and a census that's hovering between 200 and 250. And we realized that even with the current governor executive orders in place, where we're not doing elective procedures of any type, and even as we did not know for sure whether we had reached a peak in the surge, we had excess capacity. So our thinking globally was, we have this excess capacity, we have to optimize the care for all of our patients, the COVID and the non-COVID patients. So we set out to assess what that capacity was, and began an early, what we're calling phase 1A recovery, which is working through a backlog of urgent emergent cases that had been postponed. These are cancer patients, cardiac patients, vascular presentations, life and limb saving situations that have been postponed in order for us to create capacity for the upcoming anticipated COVID surge. So we have a prioritization list, similar to what Dr. Hoyt was describing, and the priority was the time sensitivity on the needs of those patients relative to how long have they been waiting and what is the nature of the needed care. The second priority was not to compete with the resources that have been allocated to prepare for treating the surge in the COVID patients. So things like ICU, expected ICU days, or need for ventilation, and so on. And most recently, for example, propofol or other pharmacologic agents that may need to be held in reserve. So we don't want to compete with that. And thirdly, safety. That was a key third priority. So testing protocols were instituted globally and things like that. So we want to be safe for the providers and safe for the patients. So we've set up a governance system. It's through a resilience and recovery committee that is composed of all of the leaders within the clinical arena, taking a deep dive into all of the areas in terms of what they would need in order to begin the phased approach at recovery, with percentages similar to what has been described, maybe 25% recovery in phase 1, and then 50%, and then all the way out to 90+ recovery. And the things that we're watching for are exactly what was described. We're watching for is a potential cluster transmission in any of the clinical areas, a resurgence or second peak in the local regional area, a potential shortage on the personnel related to either COVID sickness or other matters, including things like burnout, which was alluded to by Dr. Hoyt. And most importantly, the availability of resources, meaning PPE and pharmaceuticals. So those are the go, no-go areas that we're monitoring very closely as we proceed with implementing a phased recovery. Those will be my general comments for now. I agree with what was said, that it's very difficult to prioritize. Now we have a backlog of over 1,000 surgeries, and we have not, during the crisis, of course, I don't think anyone has expanded their operating room capacity. So it's going to be a very difficult task to prioritize those patients because the overwhelming majority of them have been waiting for over a month, and many of them have significant time sensitivity to their care. I'll be interested to hear what the rest of the panel, the entire panel, has to say about that. And I appreciate the information that Dr. Hoyt shared with us on that arena. Thank you.
Thank you very much, Dr. Velasquez. Dr. Coimbra's internet is down. Let's go now for Dr. Thomas Scalia. Dr. Scalia, what's the planning for reopening for elective surgery at University of Maryland, Baltimore, please? Dr. Scalia?
Dr. Scalia, your mic is muted. Your control is in the lower left-hand corner of your screen. I'll send him a chat, Dr. Marttos. Move to the next one, please.
Okay, so let's wait for Dr. Scalia to talking later. So you lately receive a lot of news from New Zealand. They say that they had no new case, that the country start to reopen. Dr. C, so what's the planning for New Zealand and for your hospital about reopening the country, reopening it for elective surgery, please?
Thank you. Thanks for the opportunity to discuss some of the New Zealand initiatives. But I think we need to understand from the country's perspective regarding integration back to surgery. We can definitely relate in New Zealand to the principles of reintegration from Dr. Coimbra and Dr. Hoyt's presentations. Some of you may be aware that New Zealand has been in a national total lockdown for 33 days. And this is 2 cycles of 14 days. Over the last 2 days, there's been some relaxation of restrictions, but still there is no face-to-face contact in the businesses. There's been a total of 1,474 cases. Over 6,000 testings done yesterday. There were only 2 positive COVID cases across the country. And we have had 19 deaths, and these were related to our nursing homes and aged care facilities. Our Prime Minister and Director of Health have gone for elimination of the viruses in the country. It is impossible for eradication, but the government is taking a zero tolerance approach for aggressively managing the cases and making sure that the numbers are very low. And some of the actions are effective and strict border control. Our borders are still closed at the moment. And then quarantine of the New Zealand residents and citizens coming back to the country. Effective contact tracing. And everyone was asked to keep a diary of close and probable contacts of your activities over the last 14 days. And certainly some apps are coming out for national contact tracing. And then also aggressive testing as well across the country. There's been some random testing areas in the high-risk areas, nursing homes, even in the supermarkets. And those recent tests has become, none of them were positive so far. New Zealand has a universal health system in the public sector. Our hospital has in phase 2, and that means mild impact with COVID cases. In my hospital at Auckland City Hospital, in the center of Auckland, New Zealand, we have COVID inpatients. We have no ICU patients. And we are expected to be in this situation probably over the next 6 months to a year. We have been in a COVID roster for surgeons over the last 6 weeks or so. We recently, just 2 or 3 days ago, we have stopped the roster, trying to revert to the new normal of our surgical working capacity. We have seen a drop of 25% of emergency general surgical patients admitted to Auckland City Hospital during the national lockdown. And that is because patients don't want to come into the hospital. We've seen those patients are presenting late and they are sicker. They have a longer length of hospital stay. And these include the daily cases that we manage, like appendicitis, cholecystitis, and bowel obstructions, and they usually come in sicker. So we're trying to ensure that the patients are aware that it is safe to actually come into the hospital. The risks are low. It was estimated that the healthcare transmission at Auckland City Hospital is less than 1 in 100,000. Bearing that in mind, we have already developed guidelines and triaging patients for operating theater, for clinics, and for the visitors. In New Zealand, we only have nasopharyngeal PCR RNA swabs available. We don't have anything else that is approved by the government to use, but something of more of a rapid test may be available in the next few weeks. But within the hospital itself, it is important that we still maintain a physical distancing among ourselves and team members, especially with our residents. We have stopped professorial teaching rounds, and only one attending and maybe one resident will see the patients at any given time. We have resumed teaching and grand rounds via a video link. Telehealth and video consultations in the clinics are preferable over face-to-face contacts, but we realize that we need to see our patients, and these patients will be going through a rigorous screening before they are allowed to present to the clinics. We also have a prioritization of cases throughout this period for delivery of care using the scoring systems, and also their clinical priorities and risk deterioration scoring tools are used. There is a very loose PCR testing guidelines for staff and family and people in their bubbles. And that is important that if we have any sort of possible COVID symptoms, we get tested for that. In terms of nationally, there's been discussion about a trans-Tasman bubble with Australia, and this may be happening hopefully at the end of the year once we have felt that it is safe to reopen borders internationally, and I think Australia and New Zealand will be the first two countries to have that alliance. So this is where I'm at. This is where I'm at the moment. Thank you.
Thank you, Dr. C. Let's go quickly to Dr. Tina Gardner. Tina, if you could briefly tell us the situation of revamping surgery in Norway.
Yeah, thank you. Thank you so much for great presentations and for great leadership in these meetings. I think you've been describing, both of you and Dr. Hoyt have been describing beautifully all the discussions that are, I think, happening in every single institution around. And I probably compare Norway more to New Zealand than a lot else. I think we are down on the low side number-wise so far. We have had about 7,700 positives and only about 200 deaths so far. But what we see is that we have been preparing well. And I think what we were lucky was that we had a government also quite aggressive from the beginning, starting out. If we compare to neighbors in Scandinavia, we're on the low side. I think maybe because of that aggressive approach. What they see now is that we've been decreasing over the last 3 weeks, and as you were saying in one of the presentations, is that after 2 weeks of decreasing, you should consider starting to reopen for a surgery. What our government decided a couple of days ago was to start opening again. That means everything that does not affect social distancing, because that is the absolute the thing that has to be maintained. That means so kindergartens are actually opening again because of for the smallest kids. One-to-one healthcare outside hospitals is opening again. We're allowed to travel again outside our own commune to go to holiday houses, because that has been banned for the last few weeks, and so on. And starting week by week to open slowly and very specific activities. That means no bigger gatherings, meetings are only for a few people, and so on and so forth. So for hospitals, we are in the one major trauma center in the country. the biggest acute care hospital facility. Our hospital is in 4 different locations. What was good is that so elective surgery has been maintained partly in the other locations. This is the emergency location. We were, like everybody else, had low volumes of trauma for a while because people were not moving and not being stupid for a few weeks. And then that activity has come back. So at the same time as the numbers of COVID patients is decreasing, trauma is back to normal. That means ICUs are filling up again with trauma patients. We are out, so when we wanted to start doing elective surgery in the emergency hospital, emergency cases and trauma is back to normal. And as I said, I think in previous meetings here, our focus is to try to make, so we have to really focus on maintaining quality of care for those patients who are non-COVID patients in this situation. We have had, since yesterday, actually, for the first time, we had rapid testing available, or actually this morning, rapid testing available, and that is being then, because, but very few tests, they are being only for patients who are, in order to avoid using the last isolation COVID unclear beds in ICUs, and so on, in order to try to maintain the activity at the right level. So I think we have been discussing what kind of surgery are we going to restart. Obviously cancers and so on. Other elective surgery, lots of discussions around what is the high risk and low risk patients. Which patients would you actually risk going through surgery with, and who would sort of tolerate even being infected by COVID in a post-op situation. And those discussions are, and as was mentioned, I think the most important is to have this really robust governance committee and multidisciplinary committee, because the protocols have to be changed from day to the next. It has to be dynamic. And what we see is that, yes, we open for elective surgery, but it has to be reevaluated every single day in a big emergency facility like this is. Also, we have to trust our politicians, and they've been very, very clear, more clear than politicians normally are, in giving the rules for restrictions. And what they say is that even if we open now for more activity in the country, it might be shut down again in a few weeks when we see where this is moving. So I'm looking forward to come back with more sort of an assessment and evaluation of what has happened with this over the next, in a few weeks, and see where we go. Thank you.
Thank you very much, Tina. Let me go to Dr. Thomas Scalia from Shock Trauma in Maryland to give us his perspective of his facility and a little bit of a taste of what's going on the East Coast. Tom?
Yeah, Dr. Coimbra, I believe he's still experiencing technical difficulties.
Oh, okay. Sounds good. So I want to be respectful of everybody's time. So I will take the prerogative of the moderator and ask one question to Dr. Abbo, because this is something that is being discussed in every hospital in America, I guarantee you, and in your own. The issue of testing healthcare workers and surgeons prior to the reopening. And number one. Number two, what is the real risk of acquiring this disease if you come as a patient to the hospital that has implemented most of the safety measures that we described? And then three, if you're going to test everyone, how often do you do it? Because if you do once and you don't do in 2 weeks, what's the value?
Thank you, Dr. Coimbra. So there are three complex questions, and I don't have the answers for all of them. And I think, as I mentioned in the beginning, everything changes so rapidly that perhaps in a couple of weeks, we will have a better answer. So the first question is, should we be testing every employee and every OR personnel and every surgeon to reassure your patients, hey, it's safe to come to my hospital. And my concern is when you do it and how often are you going to do it? Because the fact that you have a PCR negative today doesn't mean that you cannot walk to the supermarket or shake hands, or if you're practicing social distancing, you're not shaking hands. But if you go to any other public space outside of the hospital, you might be at risk as the city is opening. So I think we know that we don't have herd immunity, at least in the United States and at least in Florida, where the majority of the population is still does not have antibodies. We know that there is a potential risk. And so I am afraid we do need to have some sort of testing, but I don't know yet when is the right time and how often we should do it. I do think that eventually a strategy of testing antibodies and reflecting to a PCR might be something that we could do. But again, the question would be, is that something you do once a week, once a month? That's a problem. I do know, at least in our hospital, we have implemented universal masking. We have provided PPE. We have not been at surge. We are not like New York or other parts of the world where they ran out of PPE. So because both at the University of Miami and at Jackson, we have provided universal masking, I feel that we have taken extra steps in protecting our employees. We know what our rate of infection is. And I'm more concerned about the new hires. We're going to start residency training in June. We're going to have over 300 residents coming from all over the world. And I don't know what kind of PPE or protection they have been using. So I think for new hires, if you have to prioritize and you don't have, if you have limited resources, I would prioritize new hires, anybody coming from another city, another country. Definitely those, you want to have some proof that they have either, been tested by one method or the other, or a combination of methods. And then we need to have a consensus if we're going to start testing. If I start with the ORs, then the next question is going to be interventional radiology, and the next question is going to be the radiology technicians, then the clinics, and everywhere where a patient can go. And that becomes a big problem. And we don't have capacity in the United States to test the entire population. Right now, we don't. We need to get there. The second thing, I forgot your second question. Can you repeat it? You're muted.
You're muted, Dr. Coimbra.
No, I think you answer both of my questions. The value of doing it. What's the real risk of somebody getting the disease?
So the real risk, if you are not doing an aerosol generating procedure, or if you are doing an aerosol generating procedure, but you're using the protective equipment and you're taking all the precautions and you're practicing social distancing and hand hygiene, I think the risk is very low. However, we really need to analyze the global data, and that's where we need collaboration in assessing what has been the seroconversion of healthcare workers that have been exposed to patients with COVID wearing appropriate PPE. Because initially, all the infections in healthcare workers were because we didn't have enough PPE, we didn't know which PPE to wear. But if everybody has been using the guidelines and you don't have a shortage, I think the rate of infection should be very low. And so far, the infections that we have diagnosed in our healthcare workers have been in situations where they were not wearing the PPE, they didn't know, they had an asymptomatic exposure, and that's the other problem. How do you prove that it was in the hospital and not outside when you have prevalence in the community? So it's a challenging question, and then the potential litigations that come with all of this. So I do think we need to reassure the patients. I can tell you my personal family and friends are calling me. They're afraid to come to the hospital or give birth because, oh my God, what if I get COVID or the baby gets COVID? And I said, no, we're taking all the steps. We're testing you before you come to the hospital. Every employee is wearing PPE. We're compulsive about the hand hygiene, but the risk is not zero.
Thank you very much. I just want to tell all the participants that the Q&A questions, I tried to answer several as we went through this process, but we will try to answer all of them, and we'll forward to you the answers. And obviously, if I need to reach out to Dr. Hoyt or Dr. Abbo for help with a question or two, I'll do so. We'll try to answer all the questions of the participants.
Dr. Coimbra, may I make an additional comment? I'm interested in the panelists' thoughts.
Of course, absolutely.
So we're finding out that planning a phased recovery with COVID rather than after COVID. It is quite the situation relative to the absolute need to continue the physical or social distancing guidelines. And so we've had to really rethink and re-engineer the clinic, ambulatory spaces, and the workflow for the care of patients, and the logistics of having them flow through every single clinical area. Can you comment as to how this is being envisioned from a logistics perspective? I mean, we have checklists, we are putting markers on the floors, we're increasing the signage, but what else can we be thinking about?
Well, I think, you know, you cover it pretty much. We are doing the same things. We are making sure that people don't walk in the building before they are screened with a questionnaire and temperature is taken. If they are allowed to walk into the building, or let's say clinics, for instance, there are marks on the chairs and marks on the floor where people can stand or sit, respecting social distancing. For preoperative patients, as I mentioned, everybody will be scheduled for a test at least 72 hours from the time of the operation. Patients get a mask as they walk in the facility today. No exclusions. Patients, surgical patients, when they come in for the day of surgery, they will get a mask and they will stay masked until they go to the operating room for the intubation. They will get a mask immediately after they are extubated and when they go to recovery. No families in the hospital, curbside pickup, all the things that I mentioned, just to avoid this traffic of people that can bring and take with them things that you can get as you move around in the hospital setting. I think those are the most important measures for sure.
Well, I just wanted to add to the question about what can we do differently. And I think when we study quality in what has made a difference in quality in general, not related to COVID, one of the most important practices we've learned is to just slow our steps down a little bit and make sure we discipline ourselves to do the things that we know are essential to be safe. So if it's a central line, visualizing with ultrasound. If it's a blood transfusion, having two people read back the number, et cetera. So with COVID, I think the most important thing is we adopt these new behaviors and we are rushing to kind of get back to normal. We've got to discipline ourselves to slow it down a little bit, take the time to learn and integrate these new behaviors. And if we do so, I think we'll really improve our response to this.
So this is Dr. Abbo. I agree with that. And I also think that we need new policies, because we know in public health that when government mandates things change. It's very difficult to change behaviors, even though people have been quarantined for 20 or 30 days. I'm afraid that as we open the beaches in Miami, people will go back to partying in the beach, as some people have not experienced the threats. They're not in healthcare, and to many people, 85% of the population do just fine and they're asymptomatic. So I do think we need more universal global policies into what is the new normal. I think people finally understand the importance of hand hygiene. I know many of you know, and many of you have worked with me and know that we reiterate that hand hygiene, starts in kindergarten, and that is really very important. And maintaining and monitoring all these policies they're going to be putting in place in the hospital, I think it's going to be fundamental, because you can put all the marking, but if you don't have anybody monitoring the compliance, that's going to be the challenging part. And I have been visiting our operating rooms, and when you go to the post-call room, we've been monitored. People still have some social, interaction. So it's really monitoring every area of the hospital. The patients need to be re-educating, and the healthcare workers. And again, keeping the environment clean, environmental cleaning is extremely important. And understanding that this is going to take a very long time, and we need to adapt to this new normal. And as Dr. Hoyt mentioned, we have all rushed into adapting new things as best evidence, and the same with the treatments and the same with the diagnosis. We need to pause and understand, what are we doing, what is working, and what needs to be changed.
That's great. So you know, I want to just close with one comment going back to Dr. Velasquez's question, because yesterday we had a discussion in our hospital related to the fact that during crisis, in disaster management, mass casualty, whatever you call it, we try to do the best we can to save as many lives possible. And sometimes because of the resources and availability of personnel, etc., we do the best we can, but the best we can is below the standard that we practice on a daily basis. This is a very dangerous position to be. And as we reopen surgery, we need to make sure that we get away from this crisis mode when we are dealing with surgical patients in the operating room, because we want to have the excellent outcomes that we used to have prior to COVID in every case we do. Accepting substandard care or accepting an outcome that's not what it was before COVID, just because we have COVID people in the hospital, is not acceptable. So we used the example yesterday of a simple inguinal hernia. If everyone should heal fine and have no complications from an inguinal hernia, but if you have a wound hematoma that leads to a wound infection, the wound's open and the patient needs antibiotics, that is not acceptable. And justifying being sloppy or not paying attention to detail and not practicing at the highest level is just not the right thing to do at this time. So as we regroup and try to reopen our hospitals, we need to keep that in mind. The patient safety and quality comes first. And we need to go back to practicing safe surgery the way we did before this.
I congratulate you on that comment. And I think for the intensivists that are listening and partnering with your nurses, the care has to be multidisciplinary. It's not just what happens in the OR, it's the post-operative care, it's the care and maintenance of central lines. We're seeing patients that have Foley's left because everybody's afraid of touching the COVID patient. We really need to look at what's the standard of care and go back to that, with or without COVID. I really think that's a key message that has to come out of this today.
All right, so again, I'm gonna thank everyone for joining us today. I know how busy everyone is during these times. I think we learned a lot today, and we will answer all the participants' questions. And again, I want to thank Antonio for making the resources of the University of Miami telemedicine program in surgery available, to Dr. Hoyt, Dr. Abbo, Omaida, Tina, Dr. Iscalia, that unfortunately couldn't connect, for participating today. Thank you so much.
Thank you all. Another good meeting. Thank you, Gary, Valeria, to make this happen. Thanks to Gladys to work in the Panamerican website. So this conference is going to be available on the website tomorrow for anybody who wants to watch again. Dr. Coimbra, amazing conference. Thank you for making it happen. Okay.
Thank you.
See you all next week. Thank you.
Bye.